Hi, good afternoon, good morning to everyone. Just think it was a little glitch with the title of my presentation. My title of the presentation is Clinical Examination and Classification of Diabetic Foot. I'm not sure if you're aware about that, but I'll go with this. Right, as Ariel said, I'm from UK. I'm practicing in UK. Actually, I'm from Romania and working as a podiatrist in UK, and I just got my place in podiatric surgery. Diabetes mellitus is one of the commonest medical condition prevalent all over the globe. Diabetic foot is defined as the foot of a diabetic patient with ulceration, infection, and or destruction of the deep tissues associated with neurological abnormalities and varying degrees of peripheral vascular disease of the lower limb. The prevalence of foot ulceration in patients suffering from diabetes, it's about 4 to 10% in developed countries. The incidence increased with age due to long-standing combination of neuropathy, arterial disease, and associated autonomic changes. Globally, around 370 million people have diabetes, and this number is increasing in every country. Diabetes UK estimated that by 2030, 552 million people worldwide will have diabetes. Diabetic neuropathy results in sensory, motor, and autonomic nerve dysfunction, and is the most common cause of diabetic lower limb ulcers. Usually, proper management of diabetic foot problems begins with a thorough evaluation of the patient. This evaluation should include a detailed history should be obtained, including duration of diabetes, insulin resistance or dependence, existing comorbidities, previous surgeries, family history, social history, and current medication. Also, it's important to document any symptoms of claudication or neuropathy, which are very important. Classification and staging. The diabetic foot is classified based on etiology into the neuropathic foot, which peripheral neuropathy is dominant. It comes with infection or without infection. Neuroischemic foot and ischemic foot, where the vascular disease is dominant, again with infection or without infection. The neuropathic foot, mainly found on pressure areas of the foot, such as the tip of the toes, under the big toes, sides of the foot, or heels. Usually they appear to be round and have a thick callus around the ulcer. It can be present with an infection or without. It's mainly found in patients with neuropathy. The ischemic foot, ischemic means reduced blood flow, mainly occurs in PAD. Common sites of this kind of ulcers are dorsal of the toes, margins of the feet, or heels. They can appear as pink, shallow, open lesions with surrounding pink tissues. If the wound dries up, most of the time you can find black necrosis. The neuroischemic foot ulcers occurs in people who have both peripheral neuropathy and ischemia. Neuroischemic ulcers are less likely to heal without intervention, and if the infection is present, the risk of amputation is pretty high. The usual appearance is pale or yellow colored tissue that might have a hollow, thin, glassy callus. Key components of the diabetic foot examinations is we're starting with the inspection of the dermatologic aspect. We're looking at the skin status as color, thickness, dryness, if there is any cracking of the skin, sweating, if the skin is dry or it's excessive sweating, if there is any infection such as fungal infection in between the toes, if there is any maceration, if there is any open lesions already, any calluses, any blisters, any hemorrhage into the callus. Then we're looking at the musculoskeletal aspect. We're looking at any deformities, if there is any cloud toes, hammer toes, bunions, any prominent heads, if there is any Charcot deformity. We're also looking at muscle wasting, and we're talking about neurological assessment. The gold standard is 10 grams monofilament plus one of the following: vibration using the 128 Hertz tunic form, pinprick sensation, ankle reflexes, VPT, and also we're looking at the vascular assessment. Gold standards is to palpate the pedal pulses, the dorsalis pedis, and the posterior tibial. If they are not easily palpable, we should look into doing an ABPI or a toe pressure. Neurological assessment is very easy, non-invasive, and very inexpensive. As we know, neuropathy is a major component of nearly all diabetic ulceration. Loss of protective sensation is a term that is often used to describe a level of sensory loss that allows patients to jury themselves without recognizing the injury. Usually, patients that they have a neuropathy are vulnerable to physical and thermal trauma that increase the risk of foot ulceration, therefore amputation. Several documents recommend that all patients with diabetes should be screened annually for sensory neuropathy. As I mentioned before, the neurological assessment should include the 10 grams monofilament plus one of the other assessments. They are all easy to do, non-invasive, and very inexpensive. Sensory neuropathy starts with loss of pain sensation, then continues with unnoticed trauma, could be thermal, could be chemical or mechanical. Then progression of a lesion is unchecked as the patient can feel it. Then callus formation, tissue necrosis or damage beneath the callus, development of cavities filled with serous fluid, which erupts into the surface, which results in an ulcer formation. Motor neuropathy, we're looking there if there is any weaknesses and wastes of the intrinsic muscles. If there is any weakness or a wasting of these muscles, the foot start having deformities, you will see abnormal gait, and with abnormal gait, the risk of ulceration is high. Autonomic neuropathy is decreased sweating, so therefore the skin will become dry, brittle, you will find fissures or cracks. It can develop secondary infection and ulceration. Vasculopathy. People with diabetes are twice as likely to have peripheral arterial disease as those without diabetes. In diabetes, there is a macro and microangiopathy. The macroangiopathy refers to the arteriosclerosis of large arteries, and microangiopathy refers to the increased thickness of the basement membrane and also capillary damage. The baseline peripheral arterial disease is a minimum of lower limb assessment, which is essential to help to identify any underlying peripheral vascular disease and identify those at the need of a full non-invasive diagnostic vascular assessment. A minimum vascular assessment should include history, palpation of the pulses, skin temperature, and other visible clinical features. If there is any indication of intermittent claudication or ischemic rest pain, differential diagnosis of common leg symptoms, also identification of arterial ulceration and severity, and identification of venous disease, edema, or lymphedema. When one or more of the pulses is not easily palpable, further assessment is required, such as Doppler, ABPIs, toe pressures, to inform significant disease, presence of absence, and clinical management. In people with known or suspect leg artery calcification, consider further using toe systolic pressures to help with clinical decision making. All people with diabetes should once in a year should have an ABPI and toe pressure. Also, people with a lower limb ulcer, which is deteriorating or static at 2 weeks, require diagnostic assessment to exclude or confirm significant PAD and determine the need to refer to the vascular team or other special services. If severe PAD or CLI, which means critical limb ischemia, is suspected but cannot be confirmed by initial lower limb arterial assessment, refer to the vascular team urgently for further opinion and assessment, making sure we always state the key patient history and clinical presentation that justifies our suspicion. These are the interpretations for ABPI and toe pressures. As we can see, between 0.9 and 1.3 is classed as normal. Under 0.9 is classed as abnormal with or without any symptoms. Below 0.4 is severe and is classed as critical limb ischemia. And if it is over 1.3 or non-compressible, that means the vessels are calcified. It goes the same with the same idea for the toe brachial index. The 3-minute diabetic foot is out everywhere, and we should really look into it as it's an easy assessment. It looks in 1 minute what we can ask. We're looking at the patient had any surgeries, any vascular problems, any wounds, if the patient is smoking, if they have diabetes, if they have any neuropathic symptoms such as burning or tingling, if their foot is painful when they're walking, if there is any changes in the colors. Then the 2nd minute, we're looking at what I mentioned before, dermatological exam, if there is any ingrowing toenails, if there is any dry skin, if there is any corns or calluses, if there is any open lesions, or if there is any maceration interdigitally. Neurological assessment, the 10-gram monofilament. Musculoskeletal exam, we're looking at the range of motions in the joints. The vascular exam, we're looking if there is any hair on the foot or on the toes. Also, we're looking at the palpation, which could be just a basic, and therefore, if we have time or is needed, we can do an ABPI and toe pressures. The 3rd minute is what to teach. We should teach our patients to check their feet every single day. If they can't bend or anything like that, we can advise them to ask a family member or to use a mirror. We advise them to check their shoes, to put their hand in the shoes to make sure there is no any foreign bodies in the shoes. We're making sure they understand the shoe we recommend to them and make sure they are not too tight. And also the time for the specialist is mapping out the treatments and follow-up. The classifications, proper classification of diabetic foot ulcers is essential for selecting the appropriate treatment course and coordinating care for the patient. There are several classifications, although there is no universally agreed on standard, as my colleagues mentioned before. I'm just going to go through a few of them. The Wagner diabetic foot classifications, the system assesses ulcer depth and the presence of osteomyelitis or gangrene, and is from grade 0 to 5. The University of Texas, the system used 4 grades 0 to 3 and 4 stages A to D to classify the diabetic foot ulcers. The grades correspond to depth, where's the stage account of the severity of the wound by making the presence of infection, ischemia, or both. This classification is frequently used in the practice, and it is one which I commonly use. Diabetic ulcer severity score, based on the categorization of wound into specific severity subgroups for a comparison of outcomes. Assessment using this system includes the presence of pedal pulses, the ability to probe to bone within the ulcer, and ulcer quantity and location. The scores are ranging from 0 to 4. Site ischemia, neuropathy, bacterial infection, and death. Wound classifications uses 5 clinical features, as mentioned in the title, which are graded as either present or absent. The maximum score is 6. Wi-Fi classification was mentioned before, and I'm not going to mention again about it. I'm not going to go into deep, but it was created by the Society of Vascular Surgery, which realized that there is a need of classification system for the threatened limbs that compares the full spectrum of disease. And there are a few more other diabetic foot classification, the CAD system. This system uses 5 elements, the PEDIS classification, the DEPA classification, and there are some other lesser known classifications. I'm just going to mention about the MARS project, which means Manchester Amputation Reduction Strategy. It is done in Manchester, and I'm really honored to be part of a team which conducts this project. 1,000 lower limb amputations are performed annually in Greater Manchester, of which are half preventable. These projects aim to reduce the major limb amputation across Greater Manchester and bring them initially in the line with the national average, which is 36% reduction. The plan for this is foot and leg triage service. The triage service will triage, diagnose, and treat the population at risk. It will undertake a health and social care needs assessment in the line with the MARS public health framework. The triage service will offer lifestyle and risk factor modification programs and to be the center for health promotion in the community for those at the risk. Foot and leg protection services. A patient with foot and leg ulcer will be referred to the protection service. Here, there will be 3 tiers of management. Tier 1 will be with the district nurses, which will manage the most basic of the wounds. Tier 2 specialist clinics will be run by specialist podiatrists and tissue viability nurses with the most complex wounds managed at the multidisciplinary level with tier 3, and the prevention, which obviously is the key. Prevention is the key to improve patient outcomes and reducing treatment costs. There are approximately 2.8 million people living in Greater of Manchester, of whom 32.2% are aged 50 and over. The population of around 1 million will be the target of MARS project. Thank you.